A continuación, Nikolaos Kanakaris, él viene de Leeds. Gracias, Nick. Nos va a hablar del tornillo iliosacro S1 y S2, 10 pasos.
Speaking about the iliosacral screws in 10 steps, I made them 11. So these are not the 10 steps, these are the 10 principles. That I would not read them, I would give you, I don't know, 15 seconds to read them one by one. They are very important. And unless you follow these principles, the steps I'm going to present secondarily may have no real meaning. You need to study the cases. You don't just to rush in because it's a side screw fixation, which is like, let's say, the workhorse and piece of cake surgery for anyone that does pelvic and acetabular reconstruction, and for a lot of other trauma surgeons. Occasionally, you need the post-op CT as well. I would highlight that. And definitely, we do them when we have symptoms or we have doubts. If you are in the learning curve of your service, better do them in all cases, because then you will understand what you were seeing yesterday on the fluoroscopy, if it made sense, or you have a false impression of things. And if you see a problem, address it early. Don't just hide your head in any kind of sand. You are not an ostrich. We always remove it in developing skeletons and young ladies that are going to have a delivery in case they can avoid a cesarean. So these are two questions that I kind of send. I don't know if they're going to present into a voting whatever system. Yeah? They will? No? Okay. So we jump over them. Forget them. So it is the workhorse. It has been described a few decades ago. And it's attractive because it's minimally invasive. It is relatively fast. It is totally mechanically sensible to what it offers, lagging or position fixation of, in the correct axis, usually. And it's relatively safe. I would say that if you compare it to other open approaches that you can do to the same area. Yeah, it is relatively safe. It uses, obviously, fluoroscopy or other means of guidance. There are basically two types of screws, the oblique ones and the transsacral kind of horizontal ones, depending on what you want to address. For example, here you see a combination. Biomechanically, if you believe to the biomechanical studies, they all have their own limitations. However, these points make sense that two screws are better than one. If you have a more unstable, obese patient, etc., more unstable fracture, it makes sense to have two. If you fire one across the transsacral corridor, maybe even transciliac, obviously is better than two bilateral or two different levels in a single side. If you offer vertical stability as your first priority, then the S2 corridor is better. If you want rotational control, the S1 is proven biomechanically to be better. If you have usually a combination of instabilities, you need both corridors. So common sense. Complications, they do have ones, quite common or not, depends on your experience. And they are usually related to the implant malposition. Depends on what that hits and where it produces the problem. If it's over, obviously, the sacral ala, it will be an L5 nerve root problem. If it is through the sacral planes, depends on which foramina may, or nerve root impinges, it will be an S1 or S2 symptomatology. Occasionally, you may see, maybe in a publication, screws through the spinal canal. You can have access problems with bleeding through your lateral mini approach. And they describe even other complications if you go and exit anteriorly, where is the big reach, venous sensei and arterial plexus. So, step one, preoperative planning. What is the patient? Go and see the patient. Don't be surprised because he landed on the bed before you actually scrubbed or you entered the theaters. Check about associated injuries. They may be influential. Soft tissue environment around the area you are targeting. A Morella Valley there may make a problem or not. Or if still you want to fix it, at least know about it. Check your equipment, what screws you are using in your hospital, with cannulated system. Usually we use 6.5 by 8. The majority in our institution take 8mm screws. Somehow they are bigger, I don't know, size patients, but I believe the corridors are enough for 8mm in a lot of the patients. You can measure them on the scan. You need long screws if you are aiming traciliac. And of course, you need an appropriate table. I like the table if you have this option that can roll side to side. This helps instead of rolling the X-rays or pushing the patient to make sure that you have a correct trajectory. By rolling gently the table, that helps. Now, sacral dysmorphism. If you read the literature, it says about 8 to 10%. I don't know, in my patients, it's much, much higher, but it has a variance, a spectrum. Can be very bad sacral dysmorphism or not. So it is a problem. It has its own signs. You can read about them. I'm going to waste my time to that, but you can check that if you have this kind of configuration, you have a problem. Your S1 corridor is compromised. I don't choose it. I don't use the O-arm or CT guidance or navigation. We had and we sent it away because we were wasting time. I use the S2 corridor if I have such a pelvis or other means of fixation. Regarding positioning, yes, usually supine or prone, usually the legs together. I've seen also a film that you tie them together is a reduction maneuver for sure. Don't have them in any external rotation. I overlap the toes and the foot. This actually brings reduction and it's proven to be like that. I kind of isolate, drape, and see my targets. Crucifix the arms to have access for your laterals. OSI with rotational. And make sure that the screens are where you can look at. Unless you are driving to park your car, you're going to be looking where you are aiming. So don't fight yourself. Landmarks. Okay, you can use landmarks. We use fluoroscopy. I always mark the midline. The umbilicus is a very unstable mark. Don't use this as a mark. The patient may have a distorted pelvis, or the umbilicus is all over the place. So use fluoroscopy to mark in an AP, through AP, where is your midline. It would help you when you guide the radiographer to go laterally, medially. You know where is the midline, he knows, so he can target what you want to see in your trajectories. Now, the reduction. Yes, you can use bumps if you have, let's say, a crescent or an SI joint that you want to push in front. Bring the patient to the side, legs we set together. Yes, the C-clamp, that's the most useful part of it. It can be a reduction big clamp. As a fixation device in the damage control scenario, very, very extremely used nowadays. It can be useful if you don't have a pelvic surgeon there. Usually you have the binder, he comes to theaters, you are able to fix, temporize with screws. So unless you cannot do that, and usually we combine it with an X-fix. We heard an example that it opens if you just use it in isolation in some patterns. So in combination, but it's exactly on the corridor more or less of your SI screws. You can use axial traction, you can use the star frame, or you can use a simpler device, which is like a plain X-fix across the table. Or you can use a clamp if you have an open approach. This is a crescent type 3 fracture that you want to clamp, and then you want to lag. And then remember, it's very, very important to have the reduction, or else the screws may guide yourselves into big problems. Reduction is of paramount importance. 5. First view in my hands is the lateral, a true lateral. It's important to have the center of the S1 in your lateral, because or else you have a parallax phenomenon. Besides the rotation of the patient, the distortion of the field of the X-ray. So what you are targeting, put it in the center. And so the alar slopes will look together, although this may look oblique. This is the important part. This is secondarily of importance. You can be lucky and have both in one line. So you need to know your landmarks, what is the alar slope, what are the lines you see, what is this, what is that. So know your anatomy on your fluoroscopy and radiology. You can use this to guide your secondary procedures. And so you can mark on a vertical plane with, a wire, how it trajects on a true lateral, let's say. And then you can ask them to rotate. So this is vertical to the floor, as it is in the real life. And then you will know what is the trajectory of your inlet. Because the inlet trajectory at the outlet, obviously, which is 90 degrees to the other, they vary. And you can prepare your radiographer, because they never understand what you tell them. So if they know 15 degrees, 30 degrees, 48 degrees, they can do that and reproduce it. And you can mark yourself if you have an inexperienced radiographer or very small patients. 6, skin incision is over obviously below the Aller slope, you are aiming for the S1, for example. You're going to mark your skin, you're going to dissect bluntly. Guide wires, it is useful to be non-threaded. If you have non-threaded guide wires, use them. At least 2.5 or even bigger in diameter, so they are not very flexible. If you are doing children, then you may end up using 1.6K wires because the screws you're going to put is 4 millimeters. So that you will understand how difficult it is to have a flexible guide wire that fights you. Now, if you aim for a transsacral screw or an oblique screw, you start in a different, obviously, entry point. You tap it then with a mallet after you have it where you want it. And then check the inlet and the outlet. The good inlet has a description. This line is to be single, or you have measured it as we said. So you can ask those degrees. And make sure that you don't hit the patient here. Yeah, make sure that this is elevated. Many times they just roll it and they damage the patient for the amount of times they do it. So make sure it has clearance. The outlet is, again, needs to be well described. Make sure that your outlet is in the midline so you can see at least one of the two foramina. One may be disrupted or the shadows don't help you. If you have both in line, I think it's much easier to orientate. Now, 8 and 9. So after you've seen that your entry point on the inlet and outlet is to find your trajectory. Usually the entry point is correct. If it is not correct, then you need to go back to the lateral. If it is correct and your trajectory is the problem, then that's much easier to solve as you are. So what you need to do is to realign yourself. If you are again in the beginning of you can mark next to your patient what is anterior, what is inferior, what is superior. That helps you just on the drape. You can use such a trocar. This is also useful because the wire, if you want to direct it, bends, it's difficult to find a new corridor. With this, you just over-drill on the periphery, and by having a much more rigid tool, you can direct yourself to any direction you want. So that is also useful. And you can go as across as you like, and then you get, an inlet obturator that brings you, the side of your ilium. You measure. Depending on the bone quality, obviously, you can use a fully threaded or a partially threaded. Still, it can be lag. If you do by, intention, so you over-drill the proximal cortices, so you can have still a fully threaded and be in a lag mode if you want that, especially in poor bone stock. That's what I do. And you can go all across as needed. Now, if you have a reduction, this is the previous case, sometimes the screws of your Farabef are in the corridor of S1, so still I want to lag the SI joint. So then I put a position screw, which is transsacral on the S2 corridor. Then I can remove the Farabef, and then I start from the back to the front to have an oblique compression screw to my SI joint. I back up the first screw, and then after I have measured, etc., I can then have the effect of lagging and close the SI joint. As you can see, much better, let's say. So the trajectory of your compression plays a role. If you are aiming to lag the SI joint, you need to be from back to front and from inferior to superior if you want to close it. Or else it will be a position. This is the conclusion. You've read them before. I'm not going to waste time. Thank you. This can be a lot of fun. Pelvic surgery is always a lot of fun.